CPD night organized by the Sri Lanka College of Specialist Family Physicians as part of the ongoing CPD program. So the objective of this program is to facilitate a learning environment among primary care doctors. This is in view of promoting knowledge and skills development and sharing new and updated knowledge through specialists in various fields of medicine. We warmly welcome you all tonight to this program. The topic today is common breast diseases in primary care. And our speaker today is Dr. Kanchana Wijesinghe. Dr. Wijesinghe graduated from the Faculty of Medicine, University of Colombo. She excelled in surgery from early on, and now she's a consultant surgeon with a special interest in breast surgery. She's also a senior lecturer with the Department of Surgery, University of Sri Jayewardenepura, and she works in the Professorial Surgical Unit, Teaching Hospital, Colombo. So before we start the program today, let me go over a few housekeeping rules. First of all, please rename yourself with the name as it should appear in the certificate of participation. Please keep your mics mute and your video switched off. If you have any questions, don't hesitate to put it in the chat box. We'll address all of it at the end. You will get a certificate of participation, but this has two prerequisites. Number one, you have to follow the lecture for at least 75% of the time, and this time does not include the discussion at the end. And also, you have to fill the feedback form with your correct details, again, as they should appear in the certificate of participation. So without further ado, Dr. Kanchana, over to you.
Thank you very much, and thank you for that kind introduction. It's so nice to see so many participants at this time of the night. I wasn't expecting that many. So thank you very much for inviting me. So it's actually a discussion about the breast disease is very, very important among all doctors. And I think it's a very timely discussion. I will try to finish it quickly, and I will only discuss what is relevant and important for us as family physicians. Right. So don't worry I'm not going to delve into too many details, but basically the learning outcomes of today's lecture is to briefly recall the anatomy of the breast, what is meant by triple assessment, which is very important, touch a little bit on the benign breast diseases that are commonly seen, commonly presenting to us, and on malignant breast disease. I will touch a little bit about gynecomastia as well, because you will encounter patients coming with gynecomastia. And then, of course, you're all welcome to ask questions, and I'll try to answer them as much as possible. Right. So breast is also a modified sweat gland that lies on top of the pectoralis major muscle. It has a huge functional importance in females to produce breast milk. So that's how it lies in between the second and the sixth rib, and between the lateral board of the sternum to the mid-axillary line. So if you feel a lump, the importance of knowing this is, if you feel a lump in the axilla, do not forget to consider whether it is a part of a breast lump. So if you look at the breast, there are two main components: the glandular component, which is mainly developed to produce breast milk and to excrete breast milk. And then you have the stromal component, the fat and the fibrous tissue that is there to support and keep the glandular breast tissue in place. So you can get various problems. Either it could be arising from the glandular tissue or from the stromal tissue. For example, breast cancers, they commonly occur from this glandular tissue, whereas you can get fat necrosis, fatty lumps, sarcomas arising from the fat and the fibrous tissue. Now, as said before, clinical presentations of various clinical presentation of breast disease is very, very common at a primary care level. And they present not only with a lump, which is traditional, which we all know, a patient can present with a breast lump, but they can also present with various other symptoms like a breast swelling, pain, nipple discharge, a change in the nipple, a change in the skin. So as doctors, at the end of the day, we need to work out what this is. So with the clinical presentation, we'll have to take a history and examination and decide, could this be a benign condition that we can slowly handle, or should we suspect a cancer and formulate a fast-track service for the patient? So basically, this triple assessment is a foolproof system that will help us all in diagnosing a breast disease. So once a patient presents to you with any form of complaint regarding the breast, there are 3 arms that you should carry out. First one is the clinical assessment. You will do your history and physical examination and arrive at your own diagnosis. Then you have to, depending on the age, which I'll discuss a little later, have to order an imaging. You can't on your own, I mean, anybody can't, we can't just conclude a diagnosis following physical examination only unless you think it is a normal breast examination. If you do feel there is something abnormal, you have to go ahead with imaging and see whether there is actually something wrong in the breast. So let's say we proceed with imaging, and the imaging also supports that there is an abnormal lesion or a abnormal area. Then you have to go for a histological diagnosis, either with a FNAC or a true cut biopsy. And that will complete our assessment of the breast disease. And at 99% of the time, we are able to arrive at a diagnosis. So if any patient presents to you with a breast disease, always stick to this triple assessment rule. Right. So what do we generally consider in the history? So if a patient presents after 40 years with a new onset lump, we are always worried whether it is breast cancer. But of course, if it is in the early 20s, 30s, it could be benign, but both have to be kept in mind. And then you ask, of course, a normal history of where is the lump, the onset, duration is important. Is it a short duration or a long-standing lump? Pain is generally associated with infection or benign conditions. So all these things give us a rough idea about the disease. And it's very important to ask whether there were recent onset nipple or skin changes associated with the presentation. If by any chance a patient presents with a nipple discharge, it is very important to ask the color of the discharge, because yellowish, greenish, whitish colors are very common and they are normal. What we have to be worried about is the watery discharge and blood stain discharge. These 2 discharges developing recently should be dealt with caution, because this might be a ductal carcinoma in situ. So if somebody is presenting with watery discharge or blood stain discharge, we have to be careful. Right. Then, of course, we'll ask about the risk factors in the history, the breast disease, whether they had any past history of breast disease, family history of breast disease. Now, remember, the use of oral contraceptive pills is no longer considered as a risk factor. It is the hormone replacement therapy that is a risk factor. So generally during the perimenopausal period, when it becomes difficult to tolerate the symptoms of menopause, some females do take hormone replacement therapy, there is nothing wrong in taking them, but it slightly adds the risk of developing breast cancer. The use of OCP no longer adds any risk. And then added to this, early menarche. That means if a female has had menarche before 12 years and menopause has occurred after 55 years, that means they are exposed to a lot of menstrual cycles. And that means in turn, the breast is exposed to a lot of estrogen. So because of that, they are also at a slightly higher risk. Smoking, alcohol, and lack of breastfeeding are also there. So once you take your history about the disease, look at the risk factors, then you take your usual history, and then you get a tentative diagnosis. Then you have to do your proper breast examination. Now, this is very important. When you're doing the breast examination, always try to position the patient at 45 degrees. Because then you get a better access to the axilla as well as the breast. And get the patient to keep the hand under the head. When the patient keeps the hand under the head, it gives a flat chest for us to examine the breast. This is especially important in patients who have large breasts. And of course, having a chaperone and exposing the patient adequately is important. So once you've done that, you got to first do the inspection. Look for any scars, skin changes, ulcerations, any asymmetry in the breast. As we go on, I'll show you some pictures of why these become relevant of our own patients. The nipple changes, and don't forget to inspect the axilla as well. So you look at and note down all these changes during inspection, and then you step into your palpation. So generally what we advise is to approach the area of abnormality last. Okay, so you examine the normal areas in the breast and go to the place where patient is complaining last. It is very, very important to use the flat of your fingers. The moment you start examining a breast with the tip of your fingers, you will start feeling lots of nodules, because generally the breast is anyway nodular. But if you want to feel a proper discrete lump, use the flat of your fingers and use circular motions around the breast to feel. And then when you're documenting, use a scientific way. So we generally categorize the breast into 4 quadrants: upper, outer, upper, inner, lower, outer, and lower, inner. At the same time, don't forget, you also have the axillary tail and the subareolar region. So you can then document there is a lump in the upper outer quadrant region, 2 centimeters, etc. So you palpate. So this is a classic example. So this patient assume has a lump in the upper inner quadrant of the left breast. So you will draw a mark and then you will describe your features in the palpation regarding the lump. So as said in this slide, if it is a firm to hard lump with irregular surface and irregular margins, fixed to the skin or the chest wall, with nipple retraction and skin dimpling, most likely you're dealing with a breast cancer. Then once you've done your breast examination, it is not complete unless you do your axillary lymph node examination also. So likewise, you can check whether there are palpable axillary lymph nodes. Now, at the end of your examination, obviously, you'll come to a certain diagnosis. This could be a benign lump or this could be a suspicious lump. Whatever it is, the next step is then you have to proceed with your imaging. So general cutoff is if the patient is less than 40 years, go ahead with the ultrasound scan, because in females less than 40 years, the breasts are quite dense and it becomes very difficult to read a mammogram. So ultrasound is the best choice for less than 40 years. But if they are above 40 years, you can couple an ultrasound scan with a mammogram. Now, one question that a lot of people ask is whether mammography is unsafe because there is radiation exposure. And they sometimes females feel worried to do this. So the answer is clearly no. There is very small amount of exposure, 1/20th of a chest X-ray. So you can imagine the minimal exposure they have, and the benefit of doing a mammogram far outweighs the risk of radiation exposure. So you can comfortably tell any patient, don't worry, there is nothing wrong, there is no risk of doing a mammogram. So if the mammogram and the scan shows that there is something wrong, you can go ahead with a FNAC or a co-biopsy. Now, how do you decide whether it's an FNAC or a co-biopsy? FNAC will only take some cells out and give you a cellular diagnosis. That is good for very small lesions. But if they are suspecting a cancer, go ahead and straight away do a co-biopsy, because the histological diagnosis will give us much more information and false negative rates are less with co-biopsy. All right. So that's about how you will assess a patient. Don't worry, 90% of the patients you assess will end up as having benign breast disease. Only 10 to 20% will end up having cancer. So because of that, now we start off with the benign breast lumps, and I will only discuss what is really important. Breast lumps, there are hundreds of conditions that can occur in the breast. But you don't have to know all of this. We will only see what is important. Okay. So you can see in this chart, when we talk about breast lesions, so many conditions are there. But let's discuss some important conditions that you will encounter. Let's start with the fibroadenoma. So I'm sure you all have had patients with fibroadenomas presenting to you. It's a very common condition. It's the most common benign tumor of the breast. You will see females in the age group between 15 to 25, even up to 35, females will present with fibroadenoma. Now, don't worry about a fibroadenoma. It's just a hyperplasia of a lobule. This is not precancerous. This is 100% benign. So you can reassure the patient very clearly that if it is a fibroadenoma, this will not turn into cancer. Patients classically present with a painless swelling. And when you feel this lump, you will feel a nice smooth lump like a ball, firm, well localized, smooth margins. And we also call it a breast mouse because it's highly mobile in comparison to the breast cancer. So of course, as I said before, what you will do is if you feel a lump, you will do an ultrasound scan and confirm your diagnosis. And you can even go ahead with a FNAC if you feel not happy with your diagnosis. But ultrasound scan generally is enough. So fibroadenomas are generally hormone sensitive. So they do enlarge during pregnancy, but they gradually involute after menopause. So the biggest thing is, what is the management? Now, if you have a confirmation of a fibroadenoma following ultrasound scan, first thing to do is reassure the patients. Generally, if it is less than 3 or even 5 centimeters now, we recommend a regular follow-up. That is, we tell the patient to be seen once in 6 months, just to see whether the lump is increasing in size. Okay. There is no need to offer surgery. The only place to offer surgery or do a surgical referral is if the lump is growing more than 3 centimeters, patient is complaining of severe discomfort despite reassurance, patient psychologically really disturbed because of this lump, or it is some kind of a complex type of lump. And also, if the patient is above 40, it is unlikely for a patient to develop fibroadenoma at this stage. So it's always good in this category to do a surgical referral. Now, as I said, there are certain complex types of fibroadenomas, which I'll show you in a little while, like this patient. So sometimes these patients develop large fibroadenomas. These are called giant fibroadenomas. Although they are benign, they cause gross deformity to a young female. So this was a 20-year-old female presenting with bilateral large fibroadenoma. We excised one at a time. In the picture in the right-hand side, we have actually removed the left large fibroadenoma and the patient ended up with the normal size breast. And we address the right fibroadenoma later. So giant fibroadenomas can be very disfiguring, and also they can sometimes be phylloides tumor, which I come later. Giant fibroadenomas phylloides can mimic a giant fibroadenoma. So when there's a patient with a large fibroadenoma, for y'all, if it is more than 5 centimeters, make sure you do a surgical referral definitely. So within this spectrum of disease, the next thing I want you all to know is phylloides tumor, because phylloides tumor looks just like a fibroadenoma, but there are major differences. First one is, phylloides occur commonly between 30 to 50 years in comparison to younger females for fibroadenoma. Also, these are large, fast-growing masses. Commonly, if you notice, fibroadenomas are 1 centimeter, 2 centimeter lumps that the patient has had for a couple of years. Whereas phylloides, within months, they rapidly grow into large tumors. And they don't have that characteristic smooth margin. So this is one patient who had a large phylloides tumor. Now, the problem with phylloides is it has a spectrum of the disease. So that means it can be benign, it can be borderline, or it can be malignant also. So because of this, these patients they definitely require a wide surgical excision. So if you are seeing a large lesion and the ultrasound scan is suspicious of a phylloides tumor and your biopsy shows a phylloides, an urgent surgical referral is required. Right. So if you all do have any questions, you can put on chat. I'm going to continue presenting, hoping that you will understand, and maybe we'll discuss questions later. But you can put them in the chat now, unless otherwise you will forget. Now, another very common condition that you will see in your practice is breast cysts. So generally, these patients present with breast pain. You will not find anything on examination. Examination is normal. But because patient is complaining of pain, most likely you will do a scan. And the scan will say patient is having cysts. So how do we deal with this? Now, classically, cysts are seen in women in 40s. These are fluid-filled sacs within the breast. And now, essentially, breast cysts are benign. Now, if the ultrasound scan says it's a simple cyst, don't worry. It's conservative management. You don't do anything unless patient has a large cyst and she is complaining of pain, then there is a place for aspiration. Simple cysts are extremely harmless. They never turn to cancer, so you don't have to worry. But if the ultrasound scan says there is a complex cyst, complex cyst means, if you look at this picture, a cyst is a water-filled sac with a clear single lining. A complex cyst means there are a few septa running in between. And there are small solid areas in the cyst. Then we are little concerned. So if the scan says there's a complex cyst, then that definitely needs a further assessment with a histological assessment with a biopsy or aspiration, right? So that's about breast cysts. So what happens when a patient has breast cysts? The breast attempts to get rid of these cysts by activating the inflammatory process. So a chronic inflammation sets in around these cysts and gives rise to fibrous reaction. That is why you must have commonly heard, this is also something you will notice in ultrasound scans, they write fibrocystic disease or fibrocystic changes. These are fibrous reactions that are occurring around the cysts. Commonly, these are very harmless. They give rise to pain and tenderness. That is all. So if the scan says it is fibrocystic disease, we stop there. There's nothing to biopsy. We reassure the patient and give some pain relief. All right. So nothing to worry about fibrocystic disease. Right. So now we come to another new topic among benign breast disease, that is mastitis. You must have encountered at least one patient during breastfeeding coming with mastitis. So it is very important for you to know the exact management, otherwise that mother and the little baby will suffer. So lactational mastitis is the commonest form of mastitis. What happens is, generally we see this in a new mother in the first 2-3 weeks trying to establish breastfeeding. So what happens is, they are struggling to establish breastfeeding, and this ends up with cracked nipples, engorged breast milk. So via the cracked nipples, Staph aureus from the baby's mouth enter into the lobules which have milk. And this milk becomes a good medium for the bacteria to grow. And because the mother is also struggling to breastfeed and there are stagnant milk, the bacteria will nicely grow and form infection. So this young mother will present to you, a lactating mother with fever, very tender breast, red breast, swollen, and will ask for some sort of treatment. And I think this condition is very important for the family physicians to know, because these mothers are looking for the nearest doctor to get treatment. It is so difficult for these young mothers to come looking for a surgical clinic in a faraway hospital, wait in line for a long time and get their treatment done. Is so cumbersome. So the nearest doctor is the best doctor for the mother, this type of mother. So what you will do is, the moment you see that this patient is having mastitis, first thing you will say is, continue feeding or at least express the milk. What you don't want is the stagnant milk. That is the medium that the bacteria is waiting for. So immediately you tell the patient, express the milk, continue to feed, there is no problem. And they require adequate pain relief because this is very painful. And you can start an antibiotic like flucloxacillin to target the Staph aureus. Now, once you do that, the next important thing is you have to make sure this patient doesn't have an abscess. So you start your antibiotics, encourage breastfeeding and see them in about 2 days. And if it is not settling, you have to do an ultrasound scan to make sure there is no abscess. If there is an abscess, you have to immediately do a surgical referral because they need this abscess needs a drainage. Otherwise, it will not settle. So remember, if you see a patient with mastitis, these are the things you have to do in a lactation mother. Start antibiotics, encourage breastfeeding, pain relief, regularly follow up this patient because they require a lot of attention. And if it's not settling, urgent scan and guided drainage. Now that is for lactational mastitis. But if you do have patients presenting in 50s with mastitis, do not discharge them or do not send them with antibiotics. You have to exclude inflammatory breast cancer because inflammatory breast cancer classically presents as mastitis, but disease in patients above 50 years of age presenting with inflammation, right? Now, another form of disease that you might see is this. Now we generally see this condition. It used to be common in the Western world, but now you see, because we see a lot of people smoking, young females in their 30s, 40s, presenting with periductal mastitis, or around the areola, they present with inflammatory changes. This is not settling also. You give a course of antibiotics, they again come, right? So this is mainly, if you go back into their history, they will have either they are smoking or they have a close contact with somebody who's smoking. So periductal mastitis is associated with smoking. It's a very painful subareolar mass. They are not. It can occur generally. Occurs in non-lactating females. So you have to do the triple assessment, and if the ultrasound scan says it's a periductal mastitis, stop smoking, start antibiotics, and if this does not respond, do a surgical referral. In the same spectrum, I'm sure you must have seen some patients coming with granulomatous mastitis. This is a very difficult condition to treat. But if you have a patient coming with mastitis and the scan says it is granulomatous mastitis, they have to be given intralesional steroid therapy to control the disease. So they require a surgical referral. Few more things. I'm sure some patients must have presented to you with breast tissue in the axilla. Most of the time they come because they are worried it's a cancer. Some patients are cosmetically worried about the cosmesis. So these are called accessory breast tissues. They become prominent, especially after breastfeeding. You can reassure them, but please do the triple assessment, do a scan to confirm it is simply only breast tissue. Then you can reassure. If the patient is not happy and wants a surgery, yes, there is provision for surgery to remove these accessory breast tissues. So you can refer them to the surgical clinic. Right, so that I said lots on benign breast disease. I'm just briefly touching so that you get a little bit of an overview. Right, now the next thing is mastalgia. This is one of the commonest problems. I'm sure you must, so many females come and say, I have mastalgia, breast pain. And then we have to turn around and consider, we have to think what would be giving rise to this mastalgia, because anything under the sun inside the breast can give rise to mastalgia. So we have this simple way that we try to work it out. First, try to see whether this is a cyclical or a non-cyclical mastalgia. Cyclical means the pain occurs just before menstruation. All right. And it goes down with menstruation. So this is normal. This is the breast's response to estrogen. The patient characteristically says just before periods, it becomes painful and then it settles. So this is normal, physiological, you can reassure. But if the patient is saying that the particular pain, there's a particular pain in one area of the breast persisting, not related to periods, then this could either be a fibrocystic disease as we discussed, or it might be something sinister. So make sure you do your triple assessment scan and mammogram as relevant, and make sure there's nothing wrong. All right. So if you find nothing wrong and still the patient is grumbling, saying there's pain and asking for something, then these are some of the things you can do. So you first of all tell them to wear a proper bra. Then you can give some simple analgesia. There is a place for vitamin E and primrose oil. It is not scientifically proven, but some studies show 50% of the pain responds to this. Might be a placebo effect, but it works. So you can trial these things and see. Once the triple assessment says there is nothing wrong and only a fibrocystic disease or cysts. Right. Another very important condition that our females are reluctant to talk about is macromastia. But nowadays, to our breast clinics, a lot of patients present. These are called megalomastias. They really suffer from extremely large breasts. They have fungal infection in the inframammary fold, severe back pain, no proper undergarment to wear. Psychologically, they are really down. Physically, they are suffering. And because of this, we offer them surgeries called therapeutic mammoplasty. This is not for cosmetic reasons. This is purely to improve their quality of life. So if you get a patient with large breasts complaining of back pain, you see fungal infection, you see brass straps cutting through in the shoulder groove, it might be, they might not come out with it because they are shy and embarrassed in the Sri Lankan population. But you can offer these patients and send them to breast clinics to have a discussion with the breast surgeon and see. I mean, it is up to you all. Family physicians are the ones who will encounter these patients. And you can offer this and show them that these kind of surgeries are available. Another patient. Right. So now we go into nipple discharge. Sorry, I'm talking too much. I will quickly finish the slides. So the next important thing is a female can present with a nipple discharge. So how do you work about on that? So if a patient presents with nipple discharge, what are the alarming signs? If they say it is unilateral, only one breast, be worried. In one breast, if they say only one duct is discharging, not many discharges, be worried. And if they say it is clear or blood-stained, be worried. So if it is bilateral, multi-duct, this is generally physiological. But if they come and say it is coming from a single side, and I can only see one duct discharging, and it is watery or blood-stained, I think it's best you refer to a surgical clinic. The next now we are slowly we are finishing the benign and we are shifting to the cancers. So there is one condition that is in between the benign and the breast cancer, that is Paget's disease. Now Paget's disease is a cancer that is occurring in the nipple areola complex. Now you can see when you immediately look at this looks like an eczema. So you will find patients presenting like this, and we have actually seen some patients presenting late because they have been initially prescribed steroids, right? So the patient presents late to us. So how do you figure out whether this is actually an eczema or a Paget's disease? Now, eczema generally occurs in both nipples. If a patient says this is only in one nipple, then this could most likely be Paget's. And eczemas are generally very itchy, it's quite itchy. But these people, they don't have this itchiness. They just say the nipple is excoriating. And generally occurs in elderly people, and it doesn't respond well to local steroid cream. So if you're going to give local steroids, make sure you follow them up and see. And if it doesn't respond well, like a normal eczema, immediately send them to the surgical clinic, because you might be missing a Paget's. Now, problem with Paget's is they don't have a proper breast lump cancer. So it could only be this lesion that is a cancer. So it's very important that you suspect it and refer. Right. So that's about benign breast disease. Now we'll quickly go through the breast cancers. So breast cancer, it is very important for us to know, it's the commonest cancer among females in Sri Lanka. Unfortunately, it contributes a lot to cancer-related deaths. So early identification is the way forward in Sri Lanka. I'm not going to go into much details, but I'm going to show you some pictures of our own patients presenting with breast cancer in various ways. All of you know breast lump is the commonest way, but this is also one patient who presented to us. She came with breast asymmetry. You can also appreciate the nipple retraction. If you look at this, you know this patient has had it for a while before presenting. Then if you look at this patient, can you appreciate the nipple inversion in the left side? That was her presenting complaint, and just underneath that, there was a cancer. Now, this patient has presented a little late. She has come after keeping the cancer for a while, and you can see it's already eroding the skin. Another different presentation. Can you see the skin indentation here? So this lady presented to us. What she told was, when she was bathing, she noticed that the skin is dipped here. And there was a cancer right underneath this area. So this is a very late stage patient, but these are our own Sri Lankan patients presenting quite late. Then another characteristic way is the poddy orange appearance of the skin. The patient will come and tell, my skin's texture doesn't look the same as it used to. So this is the poddy orange peel appearance, classical presentation of a cancer. Then bloody nipple discharge. So what I was trying to get about from this is, breast cancer can present in any form. So it is very important for you all to complete the triple assessment. If you do it, you're safe, and the patient is also safe. So I think we've touched a little bit on the risk factors. So now that you know a little bit about breast, I've told you how to examine. I want to show you some mammograms of how a breast cancer will look like. So you can see here in this mammogram, there's a lesion here with spiculated margins. I'll show you another one here. So patients might come to you with mammograms. So when you read a mammogram, what you do is you keep them both views and compare the left view with the right view. So there are a few things you look at. You look at an obvious lesion, and you can look at if there are axillary lymph nodes enlarged. So you can see there are large nodes in this. So this is an obvious cancer. So once the scan and the mammograms done, you will go ahead with a biopsy. I always reassure patients, they become very scared, say this is minimal discomfort, and encourage them to go ahead with these surgeries. Right. So one question that these patients, one moment they are diagnosed with breast cancer, the very next question they ask is, doctor, how is it? Has it spread a lot? Can you treat it? Am I in a good place? Those are the common questions they ask. So how are we going to answer that? That is why we stage the disease. When you stage the disease, you get a rough idea about the patient's condition. So that is why I put this chart. So if a patient has a small 2 centimeter lump with no axillary lymph node involvement, you can reassure the patient, look, you are in a good situation, you have an early stage breast cancer, so we can cure you, go ahead with your treatment. But if they present a little rate, you can see the survival drops. But then how do you answer? You will say, don't worry, there is treatment to somehow or other control the disease and give you a normal life as much as possible. So let's go ahead with the treatment and somehow or other try to achieve some form of cure. So you always give a positive impact. But it is important as you go down the stage to make sure we don't falsely give hopes to the patient, but at the same time, we also don't want to be having a negative outlook. For example, in stage 3, we can say, don't worry, there's always chance of treatment. Although it has spread a little, let's quickly attend to it and treat. Of course, when it comes to metastatic stage, you can see there's hardly any survival. Now, one common question they will come and ask you is, doctor, will they remove my entire breast? One thing I have seen in my experience, some of the females, even educated females, are very worried to present with their lump because they are so worried we will remove the breast and that they will end up with a flat chest, which is true because female breast is a very important organ psychologically and physically for a female. So first thing you have to say is, even if you require complete removal, there is provision for reconstruction. And a majority of our patients can now be treated with breast-conserving surgery. Then the next question they ask is it safe to leave a bit of the breast in a breast that is already having a cancer? The answer is clear, simple, yes. Nowadays, they have found out there is no advantage of completely removing the breast. The survival benefit is the same whether you do a breast-conserving surgery or mastectomy. So don't try to do, so it's very important to reassure the patient. Sometimes patients come and say, no, this one told, that one told, it's better to remove the entire breast. Then, especially if it's a young patient, it becomes very difficult for us to convince that breast-conserving surgery is as good as mastectomy. So that is important for you all to know. So these are some of the patients who have undergone breast-conserving surgery. So in this patient also, she has undergone 50% of breast removal in the left breast. But it's hardly visible. This is immediately following surgery. You can see the scar is in the back, so hardly visible, and a breast reconstruction is possible. And we can create a breast that looks as normal as it was. So you can always say with confidence that breast reconstruction, it is an option around the country today. So the next thing is sentinel lymph node biopsy. I don't want to talk a lot about it, but it's nice to know. So those days we used to do a complete axillary node clearance. We removed all the nodes in the axilla just to stage the disease. And the patients ended up with severe lymphedema. They were suffering with no benefit. So that is why today we only do a sentinel lymph node biopsy to check whether there are cancer cells in the axilla. And then if it is positive, only we proceed for an axillary lymph node clearance. That is practiced throughout the country, and it is something that I think we all should know right now, just the concept of this sentinel lymph node biopsy. Right. So sometimes you might encounter patients who have undergone breast cancer surgery and are suffering from lymphedema. So what can you do at your level? You have to encourage arm exercises. Always educate them on skin hygiene, avoiding blood pressure measurement and venesection from that hand. If they develop even a slightest infection in this hand, advise them to come running to you because they have to be started on antibiotics very early. And lymphedema massages and exercises are very important. Unfortunately, we don't have very many lymphedema clinics. We have one at Kalubovila. So if you do have patients with lymphedema who need to learn about exercises and massage therapy, you can always send to our lymphedema clinic. It is open for anybody in Sri Lanka. We teach them and we will send them back to you. Right. Apart from this, sometimes patients might ask you about chemotherapy, hormone therapy, especially chemotherapy. Now, if an the whole idea of giving chemotherapy is, now the problem with cancer cells is they don't stay in one area. So let's say a patient develops breast cancer, the cancer cells won't stay in the breast. They will quickly enter into blood vessels and lymphatics and spread all over the body. So this is called micrometastasis. Even if the CT doesn't capture them, these patients have 1 or 2 cancer cells that have gone to the body. So even if I have done 100% clearance in the breast, if they have 1 or 2 cancer cells in the body, this is going to come out again. That is why we need a full body treatment with chemotherapy and hormone therapy. So if an oncologist feels that a patient requires chemotherapy, do encourage them. Teach them this is why we are giving chemotherapy, right? And say it is short term, maximum 6 to 8 months of difficulty. After that, the life will be back to normal. So it is important to encourage them if the oncologist has recommended this. Right. So that's about breast cancer. Little bit about gynecomastia, because you will have few patients coming to you with gynecomastia. So there are 3 peaks. You have the neonates who have gynecomastia because of the maternal estrogen. But commonly you will see the puberty, the young boys in their 15s, 16s coming to you with gynecomastia with significant psychological problems. And then, of course, you have the elderly males coming with gynecomastia. Let's take it one by one. Now, there are many causes for gynecomastia, such as alcohol, drugs, certain medications, neoplasms. So if you do get a patient an elderly patient presenting with gynecomastia, it's very important you see whether they are on any medication, on alcohol, right? Check their testes, see whether there are any testicular tumors, assess their liver function and renal function. It's very important. If everything is normal, we can categorize them as physiological gynecomastia, right? So these are some of the patients who are presented with gynecomastia. So when a patient presents, adolescent patients who present with gynecomastia, they have a significant psychological disturbance because they are ridiculed by their colleagues. They have low self-esteem. They don't want to go into sports. So these sort of patients, we generally don't recommend reassurance. They need some form of treatment. So if you do encounter these patients, it is good to refer them to a surgical clinic to get a corrective surgery done, because otherwise they are going to suffer for a long period of time, and these don't reverse. So there is no point reassuring. If a patient has had gynecomastia for more than 1 year, very unlikely it will resolve on its own. So if you think they are having significant psychological disturbance due to this, refer them to surgical clinics. So these were some middle-aged people who were very upset about their gynecomastia and wanted a surgical excision. Now, when an elderly person comes with a gynecomastia, it is very important to rule out a breast cancer. So I hope this picture clearly shows you a gynecomastia is a concentric enlargement of the breast. So when you hold it, you will feel a round mass around the nipple. Whereas a breast cancer comes in a focal area. All right. So you have to make sure when you see an elderly person to rule out whether it is a gynecomastia or a cancer. My suggestion is do a scan and send to the surgical clinic. Right. That's about my discussion or my small lecture on breast disease. I told so many things. Sorry, I bombarded you with so many information, but I thought it will be nice for you all to know this. If you have any questions, feel free to ask me. I'll try to answer them. And thank you very much for listening patiently at this time of the night.
Madam, there is one question forwarded from one of the participants to me. he or she asks, let's say 25-year-old patient with a breast lump for 3 months, not increasing in size, clinically fibroadenoma. Should we go ahead with triple assessment or can we manage it as fibroadenoma? That is the question.
My advice for today's day and age is you have to go ahead with the ultrasound scan, because we have seen cancers even at 18 years of age. So I totally agree that fibroadenoma is a clinical assessment, but the minimal next level investigation is an ultrasound scan. So if the ultrasound scan shows it's a fibroadenoma, you can stop your investigations from there and reassure the patient. All right. Although these are rare forms, if you look at the standard guidelines for any breast lump, they will recommend at least one investigation to support your diagnosis. So I will highly recommend not an urgent scan, but a routine date for ultrasound scan. All right.
Thank you, Dr. Kanchana. We have another question about the symptomatic management of gynecomastia.
Yes. So some patients, they do not want surgery. If they don't want surgery, the next thing is to find out whether there are any reversible causes, like any drugs that you can reverse. Otherwise, if they are painful, you can give some painkillers. But there are no medications to reverse this condition. So you have to reassure the patient this is a normal condition. If it is drug related, try to change the drug. If it is painful, give an analgesia. Apart from that, if they are still insistent of getting this out, then you have to send to a clinic where they'll consider either liposuction or surgery. It's very difficult to manage this, to reverse this medically. I hope I answered the question.
Yes, thank you. And we have a couple of more questions. The first one is how to manage a young girl coming with asymmetric breast development.
Yes, I've seen quite a number of patients. Now, asymmetry is quite common. Breast asymmetry is physiological, but if it is very significant and disturbing the patient, you can refer to a surgical clinic. But even if you refer to a surgical clinic, until they achieve 18 to 19 years of age, only thing that we do is we observe. We will do a baseline ultrasound scan to see if there are any sarcomas or vascular deformities that we are missing. If not, if it is pure and simple breast tissue, we accept the asymmetry and we continue to observe until they are 18 to 19 years. Most of the time, these asymmetries become insignificant or non-cosmetic. Then we just let it be. But if it is a significant difference that we have seen in a couple of patients, then after 20 years, we discuss the option of reduction surgeries and correction surgeries. So if you do encounter a patient with asymmetry, you can do a scan, and if it is normal, you can reassure and follow up. You can even get an opinion from a surgical clinic and get them back to your follow-up and follow them. So annual follow-up is more than enough.
Thank you very much. And there's one last question. Does mastalgia require triple assessment?
No. So the idea of triple assessment is so once you have done your clinical assessment, you should have so let's say there's a patient who's coming with breast pain and you've done your examination, you can't find anything, but still the patient is persistently complaining of pain, then you will go ahead, because you have to find out whether you're missing something, you will go ahead with a mammogram and a scan. Now, if the mammogram and the scan is normal, there is nothing for us to biopsy. You understand? So we can stop from there. So especially if a female is above 40 years and coming with a new onset breast pain, which is non-cyclical, do the imaging. If the imaging shows something, do a biopsy. If the imaging is normal, so shows fibrocystic disease or some cysts, you can reassure and stop your investigations from there. Now, if it is a young female coming with cyclical mastalgia, you don't need any investigations. You can reassure and send them. Because cyclical mastalgia is a physiological condition. All right. So first thing is important to know whether it is cyclical and non-cyclical. Next thing is related to their age. If they are above 40, it is always good to get a scan and a mammogram done. If they are less than 40, if it is cyclical, you can reassure and observe.
There's another question about diabetic mastopathy and whether it's a common presentation.
No, diabetic mastopathy is a very rare condition. I have seen 1 or 2 in my career, and most of them we manage with antibiotics and we try to settle it. Worst cases only they go for surgical excision. In my point of view, majority of the patients who have diabetes with breast lumps have been patients with breast cancer. If you get a mastopathy, you can first refer, I think best is to refer to a surgeon and sort out. If they say it's mastopathy, fine. But it's a very rare condition that we uncommonly see. So best is to first rule out cancer.
Thank you very much, Dr. Kanchana. So it looks like we have arrived at the end of the CPD night.
I have a question. Sorry.
Yes.
May I ask?
Yes, please.
Yeah. Is the recurrence rate the same for mastectomy versus wide local excision or breast conservative?
Yes. So let me put it this way. Breast conserving surgery plus radiotherapy is called breast conserving therapy. Now, all the studies have proven there is no survival benefit in mastectomy versus breast conserving surgery. But studies have shown a slight increase in the recurrence in breast conserving surgery that is not significant. But studies will tell that. So because of that, all other countries in the Western world today, and the newer studies are showing that breast conserving surgery has better survival, and this slight increase in risk is very minimal. Today, we cannot give the option of mastectomy to a patient who is suitable for breast conserving surgery. So straight away in the Western countries, they say you are for breast conserving surgery. We don't give that choice anymore because breast conserving surgery has proven to have a better survival, and this slight increase in recurrence is negligible. Do you understand? But for MC, if somebody asks an MCQ, yes, there is a slight increase in recurrence, but in practical point of view, the benefit far outweighs in breast conservation over mastectomy, if that choice is possible for a patient. So breast conserve, you can, without any problem, you can promote breast conserving surgery in suitable patients. And if they do ask about recurrence, we play it very safely because our patients get quickly worried. We stress on the fact that although the recurrence is slightly high, it will never affect their survival and it can be attended to. It's very negligible. You understand?
Yes, thank you. But if the patient asks for a total mastectomy,
yes, then
we
of course,
apply.
Yes, of course, if the patient if the patient asks for a mastectomy, it is patient's choice. So we have to discuss the patient's choice. But what I have noticed in my experience is all females, most of the females less than 50 years find it very difficult to accept a mastectomy. They are so pleased when they are offered a breast conserving surgery. Some people, out of the fright and the emotional status, say remove the breast, and then they come back asking whether we can reconstruct the breast later, which is a little more difficult. I have even had patients in 80s, 90s saying, look, I have lived with my breast for a long time, don't remove it. So you are right, it's a decision with the patient, but with experience also we have to show both sides to the patient and let them decide.
Thank you.
Thank you very much, Dr. Kanchana. Any more questions? Okay, in the absence of any more questions, let me extend a final thank you to Dr. Kanchana for her effort today, and also Dr. Malkanthi Galhena, the president of the College of specialist family physicians, and the chairperson of the CPD committee, along with all the members of the CPD committee and our participants this evening. Please fill the Google form that is linked in the chat box. So your certificates will be uploaded onto a Google Drive, and the link will be emailed to you. There are also a few compulsory MCQs. So the answers will be sent to you when you submit the Google form.